Wonderful. Looks like we have a few early joiners. Thank you, everyone who is here already. We will wait a few minutes here until the top of the hour and let some others join, and then we will get started. Again, for anyone who just joined, thank you very much. We have about 2 minutes left. Just going to wait till the top of the hour, and then we will get things started. Looks like we had a couple more join here. Thank you very much for joining. Just about a minute left before the top of the hour, and then I will kick us off. Thank you again, everyone, for joining us today. Okay, I think we've just about reached the top of the hour here. So I'm going to go ahead and get things kicked off for us. So first and foremost, I'd like to thank everyone for joining today. We understand as a hospice clinician, your time is valuable, and we greatly appreciate you tuning in to our educational webinar series where we take a deep dive into the topics that hospice clinicians, patients, and their families care about the most. If this is the first time that are joining one of our presentations, thank you very much for being here. Hospice Choice RX is a modern pharmacy benefits manager with services catered specifically towards hospice and palliative care organizations. With an increased pressure on hospice to minimize pharmacy costs and optimize clinicians' time, Hospice Choice RX developed its proprietary leading-edge platform, NaviScript, specifically for their needs. NaviScript allows clinicians to e-prescribe medications in minutes, lessening clinician administrative burdens and creating more time for patient care. To reduce dual entry, the platform syncs patient demographics and medications directly from hospice electronic medical record systems. Hospice Choice RX supports medication access to patients where they reside through a nationwide hospice-friendly pharmacy network. We partner with your organization's preferred pharmacies to maintain those trusted regional relationships. In addition, Hospice Choice RX offers superior PharmD clinical consultations to support hospice providers with therapeutic alternatives and deprescribing guidance without sacrificing patient care. If you would like to learn more about Hospice Choice RX or schedule a demonstration, please visit our website at www.hospicechoicerx.com. I'm now pleased to introduce our speaker for today, Chief Clinical Officer and PharmD, Mrs. Michelle Hamblin. With over 21 years of healthcare experience and 17 years as a licensed pharmacist, Michelle Hamblin brings exceptional expertise to her role as Chief Clinical Officer at Hospice Choice RX. She's residency trained, a multiple sclerosis certified specialist, and has a deep leadership experience in specialty pharmacy, infusion medicine, and in pharmacy benefit management. Throughout her career, Michelle has excelled in a range of clinical and administrative settings, from critical care and ambulatory medicine at a health system to overseeing specialty and limited distribution pharmacy operations. Her success in building vendor partnerships, leading multiple disciplinary teams, and managing complex pharmacy service highlights her commitment to advancing patient care and operational excellence. At Hospice Choice RX, Michelle is dedicated to creating and implementing meaningful change for end-of-life patients and their caregivers. She believes what sets Hospice Choice RX apart is its mission-driven culture, focused on easing the transition through end-of-life by providing compassionate support, practical tools, and effective collaboration with hospice providers. Michelle leads her team to ensure every hospice provider client is fully equipped to deliver optimal care, helping make this journey as seamless and as dignified as possible for patients and families. Without further ado, I'd like to introduce Ms. Michelle Hamblin.
Hello, everybody. Thank you so much for joining us today. As Ted said, my name is Michelle Hamblin, and I'm grateful to be able to present to you today on the topic of managing hospice patient symptoms. Throughout this presentation, you will see highlighted text as well as some additional questions throughout. Pay special attention to these highlighted phrases because they will help you gain a better understanding of the topic for the continuing education quiz that's held within our Relias platform. For our existing clients, once you gain access to Relias, please visit the nursing and social work continuing education that's titled Managing Symptoms at the End of Life. This presentation will help you to complete that continuing education. And a special thank you to the authors of that CE, hospice nurses Elizabeth Vaccaro and Susan Heinzerling. In addition, I have inserted lists of medications for your references as well as doses by symptom throughout this presentation. These are only suggestions and certainly not the only management strategies for these symptoms. This presentation, as well as the slide content, will be available to you for our clients within our education and resources section. So today our learning objectives are as follows. They're listed here. Note that this continuing education is for nurses and for social workers. We will discuss the dying process, symptoms, management, support for caregivers, and pharmacological strategies for each of these symptoms. First, let's just talk briefly about end of life. About 8,000 people die daily in the United States. The federal government actually has its own definition of death outlined in the Uniform Determination of Death Act, and it is defined as either the circulatory and respiratory system functions stop irreversibly, or the brain and brainstem activities stop irreversibly. Death can be an emotional experience and can be frightening for both the patient and the caregivers, as you may know. Hospice providers are in a very unique situation to be able to help the patient and the family to cope. Let's do our first of 4 questions here. Just think about the answer that you would provide. True or false? The Uniform Determination of Death Act from the United States federal government defines death as both the circulatory and respiratory functions stop irreversibly and the brain and brainstem activities stop irreversibly. Take a moment to think about your response if that's true or false. So this is false. As we talked about in the previous slide, the federal government defines death as as either the circulatory and respiratory functions stop irreversibly or the brain and brainstem activities stop irreversibly. I've had such great experiences working with hospices and get a glimpse of the phenomenal impact you have on patients and families. Hospices provide services to both patients and caregivers before death, upon death, and after death. Physical, emotional, and spiritual guidance is provided, and in some instances, you come in contact with those who have no experience with death. What a great opportunity for education on what to expect and to use your expertise to guide patients and caregivers. Before we discuss common physical symptoms and treatments, it's important to note common coping mechanisms for both patients and caregivers experiencing end of life and associated issues. Elizabeth Kubler-Ross is well known for developing the DABDA theory for coping with death. Kubler-Ross described the stages of coping as follows: denial, anger, bargaining, depression, and acceptance. And interestingly, not all are necessarily in all of those or in that order. Having empathy and trying to avoid taking outbursts personally from the patient are important things to remember, although easier said than done. One area of hospice care impact is assessing spirituality. It is important to be able to assess and discuss the patient's spiritual needs or their sense of purpose or meaning. Ensure that the patient and the caregiver has access to a chaplain or spiritual advisor. Use the Hope Talking Map to help guide the discussion with the patient, which I have outlined here for you. Next, let's talk about the physical impact hospice care teams can have on their patients by palliating the end of life physical symptoms. Common physical symptoms people may have include those that are listed here. Take note specifically of loss of appetite and nausea. Common physical symptoms people have may include any of these, however. We will talk about each one, and they all include delirium, loss of appetite, nausea, vomiting, pain, constipation, dyspnea, and fatigue. Although there are others, we will focus on these items today. As we begin talking through each of the symptoms, you will begin to see a theme for some of these medications. There are many products that can be used for multiple symptoms. I have listed some of those medications for you here. These medications are great to keep in mind and are available as generics. They're low cost and they can help you treat several symptoms to help keep your overall medication cost low. These are products to consider using in comfort kits potentially as well. I've listed specific products and potential uses next to each of them. For example, a product like mirtazapine or Remeron can be used for depression, insomnia, or anorexia, but there are others listed here, as you can see, for many indications. First, let's talk about delirium. Delirium is a symptom that is often misdiagnosed and it's poorly managed in general. It is defined as a sudden change in alertness, awareness, or severe confusion, and symptoms are often confused with dementia or depression. A defining symptom, however, of delirium is that changes in the patient's level of alertness and awareness occur suddenly. In cases of dementia or depression, however, the level of alertness changes more gradually. It occurs in up to 90% of people in the dying process, as you probably know. Patients may lose the ability to communicate as well, and it can create anxiety in caregivers and fear that the patient will injure themselves or others. Let's go to another question here, question 2 of 4 that we have throughout the presentation. Delirium occurs in approximately 90% of hospice patients, true or false? And as we just talked about, this is true. About 90% of hospice patients experience delirium. Now, how do we manage delirium? Non medication management might include providing a reassuring or familiar environment, only addressing disturbing hallucinations, or modifying existing medications. And that can include things like deprescribing or dose reductions. Pharmacological management may be with the products that are listed here. These are low cost generics with dosing for your reference. However, other medications and doses can certainly be used, and you likely have your favorites that you utilize as well. Other atypical antipsychotics listed at the bottom here. These medications tend to be more expensive, and they are usually medications such as aripiprazole, ziprasidone, and olanzapine. But again, those are more expensive alternatives. One thing to note, please avoid haloperidol in Parkinson's disease patients because it worsens those Parkinson's disease symptoms. The next symptom that we have is loss of appetite. Loss of appetite is both common and expected in hospice patients, but it's one of the most distressing issues, causing caregivers to feel helpless and hopeless. Hospice teams do a great job of educating caregivers about loss of appetite. It's often related to disease progression. Eating and drinking may no longer be of interest because bodily functions begin to slow. Intake may actually cause physical discomfort, and research has also shown that actively dying patients do not feel hunger, but it is okay to consider pleasure feeding if the patient so desires. Patients could lose the ability to swallow as well. Keep in mind that artificial IV fluids or food may cause things like edema, heart failure, lung congestion, infections, and aspiration. Pharmacological management can be considered for loss of appetite. I have listed some medication options with doses here for your reference. The options at the bottom can be quite expensive, so keep that in mind when selecting the appropriate medication option for your patient. Next, let's talk about dry mouth. It occurs with dehydration and in about 80% of hospice patients. Non pharmacological management could include gum or lozenges if the patient's able, wetting the patient's mouth or lips with a sponge, or small sips of water to help swallow pills. Review the medication list for that patient as well for products that may be worsening their dry mouth, anticholinergic medications specifically, and consider deprescribing those if you're able to. Pharmacological management methods are listed here for your review and for your reference. I'm sure you also have your favorites that you utilize as well. There are several over-the-counter products that may be used. The last item here I want to point out, cevimeline. It's expensive. I've only seen it used in a handful of cases where the patient is really suffering and no other therapy has worked for that patient. But again, keep cost containment in mind when selecting your particular medication for your patient. Nausea and vomiting occurs in many advanced conditions and may be caused by the disease process itself or the treatment, think chemotherapy. It often contributes to a lack of interest in food or fluids. There are several known origins of nausea and vomiting, and they include imbalances in fluids or electrolytes, dehydration, severe constipation, bowel obstruction, organ failure, anxiety, or even medications that, like we talked about, chemotherapy itself. There are several non-pharmacological interventions that can be employed, including repositioning the patient based on their aspiration risk, performing oral care after each instance of vomiting, and before and after meals, applying a cool, damp cloth to the forehead, the neck, the wrists, reducing or eliminating strong odors, serving room temperature foods or cold foods, serving small, frequent, non-greasy meals, and really identifying in relieving things like pain, anxiety, or emotional disturbances. Other things that I've seen done are to suggest non-restrictive clothing and encouraging resting in a cool place. Pharmacological management there's some strategies listed here for your review and for your reference. Haloperidol specifically is great for opioid-induced nausea, but again, it's a product that you want to avoid in Parkinson's disease patients because it makes their symptomatology worse. Ondansetron, I'd like to point out as well, is great for chemo-induced nausea. And this is even if the patient is no longer on chemotherapy, ondansetron may be a really great option for those particular patients. Here are specific products and doses again to help treat nausea and vomiting. Many of the products are available in multiple dosage forms if the patient's not able to take products by mouth. For our clients, again, we will have all of these slides for you to reference in our resources section within a few days of this presentation. But again, here, take note of the specific products and doses to help you be able to treat nausea and vomiting in your patients. Physical pain is a symptom that's feared most by patients and caregivers. So I've taken several slides to review the symptom with you. As you know, emotional, spiritual, and psychological distress can certainly make pain worse, which is why at the beginning of the presentation, we discussed the importance of addressing spiritual well-being of your patients. Ensure that pain is accurately assessed with an objective pain scale. In the World Health Organization numeric pain rating scale or the pain assessment and advanced dementia scales may be considered. It is very important to identify the type of pain that the patient's experiencing. Pain can be acute or chronic. And in addition to acute or chronic, pain can be somatic, visceral, or neuropathic. Based on the type of pain, you should select the appropriate medication to treat that type of pain. Somatic pain is more skin and musculoskeletal pain. Think bone metastasis, for example. It's described as aching, typically by patients, and you may have some other adjectives as well. NSAIDs can be used for mild pain, but NSAIDs should be in addition to opioids for moderate to severe pain. And they can actually act as complementary to one another when you use them together. Visceral pain, on the other hand, is pain in the internal or visceral organs, such as the gallbladder, for example. Consider products like steroids to help with this type of pain. Steroids can also help with things like bone pain also. So again, multi-use, multi-indication. Neuropathic pain is caused by nerve damage and often described as a shooting pain. There may be other adjectives as well, but consider products like antidepressants, anticonvulsants, or steroids for neuropathic pain, but opioids may supplement pain therapy as well in neuropathic pain. It is important to remember that pain is subjective. Only the person experiencing it can report or deny pain. Here I have listed some guidelines to help guide dosing of opioids for you. Most of the time when you have hospice patients, they come to you already experienced on pain medications. If pain is severe and chronic and the patient is not opioid naive, then scheduled around-the-clock opioid pain medication is warranted. After 7 days, a patient is considered to be opioid tolerant. So, in other words, no longer opioid naive. Always include a breakthrough opioid pain medication, typically dosed at 10 to 20% of the total 24-hour dose administered every 1 to 2 hours as needed. Certainly consult your trusty pharmacist to help you with those calculations if needed. But again, the breakthrough opioid pain medication dosing should be 10 to 20% of the total 24-hour dose and administered at that dose every 1 to 2 hours PRN. Please remember that patients do develop tolerance to the side effects of opioids, with the exception of constipation. I'm going to say that again. Please remember patients develop tolerance to the side effects of opioids, except constipation. Opioids always decrease the gastrointestinal motility, and they also increase fluid absorption from the gastrointestinal system, hence patients getting constipation. Therefore, as pharmacists, we always recommend to include a bowel regimen with an opioid, including a stool softener and a laxative. Here I have a list of medications and doses available for you to reference for physical pain. Again, this presentation and slides are available for our clients in our resource education section. And note the different options here for different types of pain, including somatic pain, visceral pain, etc. Here we have from top to bottom the products that are listed for mild pain, such as NSAIDs, opioids for moderate to severe pain, and then products for visceral pain here at the bottom. And I have put in the directions here at the bottom specifically for cramping or visceral pain so that you know the dosing there. Keep in mind, this is not a complete list here. This is a continuation of the previous slide. Each provider may have their go-to strategy, certainly, and these lists of products and doses within the presentation are purely suggestions and can be used for reference to help you. On this slide, we have products listed more for the visceral and neuropathic pain type here. Constipation, a great topic to talk about next, is another symptom that can be encountered. Different causes can include decreased intake, less activity, and opioids obviously can be causes of constipation. It can precipitate other symptoms such as pain, nausea, and vomiting. Um, Increasing fiber and water can help, but if using opioids, again, always include a stimulant, laxative, and a stool softener both. I have seen stool softeners used without adding laxatives. You don't want to do that because you'll have all mush and no push, and you want both. Always add both a laxative and a stool softener and schedule them, not just PRN when you have a patient that's on an opioid. Be careful about increasing water intake in patients such as congestive heart failure or others that may exacerbate symptoms. So certainly take into consideration the individual patient considerations. And then I also have here suppositories and enemas can also be considered. Here we have listed some medication options for you again. So again, scheduled opioids means scheduled laxatives and stool softeners. Bowel obstruction patients are a special case, so be very careful and consider products listed here at the bottom of this slide for patients with bowel obstruction. There are several different dosage forms listed here as well for your reference. Next, we'll discuss shortness of breath, also known as dyspnea or air hunger. About 80% of people with cancer experience shortness of breath in the last 6 weeks of life, and more severe shortness of breath occurs in diagnoses like COPD. Underlying cause certainly varies, but shortness of breath is strongly related to a person's physical and mental decline. As you know, aspiration risk should be evaluated, and suspected pneumonia may have to be treated with a broad spectrum antibiotic without doing imaging or cultures. But that broad spectrum antibiotic should be able to cover you. And certainly consult your pharmacist if you are unsure. Pharmacological interventions can include opioids, bronchodilators, diuretics, steroids, or benzodiazepines. But non-medication interventions are also listed here for you, and they can include sitting the patient upright, pursed-lip breathing, calm, cool rooms with a fan, or meditation to help reduce panic. Oxygen is a controversial topic and certainly a discussion for another day. Here I have listed some medications and doses for you to consider for treating shortness of breath, including those products that we discussed on the previous slide. Two products that are unconventional that I have seen used in more difficult patients. I don't have them listed here, but I did want to mention them. The first is fentanyl, 25 milligram preservative free, as well as furosemide, 20 milligram preservative free. Those particular products can be used in difficult to manage patients. They can be mixed with sodium chloride and inhaled through a nebulizer for patients who fail other therapies. Again, a little more expensive and unconventional, but listed here are the traditional pharmacological management for shortness of breath. The last symptom that we will discuss is fatigue, which is one of the most common. What's different about end of life fatigue that I have learned is that it's greater and more debilitating than everyday fatigue, and it's not relieved with more rest. It can be caused or exacerbated by the disease process itself, by medications, by increased activity with more appointments and visitors, and also obviously reduced food and fluid intake. When food or fluid intake decreases, the body attempts to conserve energy. And hospice nurses do such an excellent job educating patients and caregivers on all of these symptoms, including fatigue. Non-medication options that you can consider are light exercise if the patient's able to, hydration if able, respiration therapy, sleep hygiene methods potentially as well. Medications may include iron supplementation if the patient is anemic, but take note that that iron does have a risk of constipation with it. Antidepressants, pain management, low dose methylphenidate or steroids can also be considered. It is important to know anemia's inevitable progression at the end of life, and always assess patient risk benefit for adding more medications. I have listed here again some potential medications and doses, and options to help you treat fatigue at the end of life. Note that the bottom two products are controlled substances, but any of these could potentially be used for fatigue. Potentially, you may have your own doses and medications that you use. Again, this is just a suggestion. With the last few slides, I want to walk through the dying process and how some of the body systems are impacted. There are many trajectories that are in the clinical studies, and certainly death is very individualized, but there are three main dying processes that keep rearing their heads in the literature and have been identified within clinical trials and clinical studies. I've listed them here for you. They include the high functioning patient, and that patient eventually it's followed by a rapid functional decline, such as cancer patients. The second process is organ failure with repeated exacerbations and a steady functional decline. Think congestive heart failure, liver failure. And third is frailty and a slow, gradual decline over years. Think Alzheimer's disease patients. Knowing what to expect during the dying process can empower patients and caregivers to create reasonable goals with you as their hospice care team. Let's first discuss the circulatory system. The patient's body temperature may drop, and arms and legs can become cool to the touch because blood is being redirected to vital organs. The heart rate and the blood pressure can be erratic. It can be difficult to detect those. And something called mottling occurs. This is actually the appearance of blue, purple, or red skin patches, first seen on the soles of the feet, the hands, and the knees, and occurs because of decreased circulation to the skin surface. Some caregivers want to try to use electric blankets or heating devices, but really this is something that should be educated, that this could lead to skin burns and other issues. Let's pause for question 3 of 4 in the presentation. A sign of the circulatory system shutting down where red, purple, or blue skin patches appear is called mottling. Is that true or false? Just take a moment to think about your response. And this is true, as we just talked about, that certainly mottling is where red, purple, or blue skin patches appear. Next, let's talk about energy. We talked about fatigue affecting many hospice patients, and that during the dying process, patients may sleep more, have less energy, or even have trouble lifting their head. What may be confusing to caregivers is some patients may experience a rush of energy or even ask for food all of a sudden after days of having low intake. Hospice care providers are really in a great situation to educate that some patients display this surge of energy in the final stages before death. The dying process also creates a chemical and a hormonal imbalance, causing more sweating or diaphoresis. Patients may have itchy skin or skin breakdown over bony areas. I'm sure you've seen it on the hips, the back, the heels, the ankles. An organ shutdown also causes metabolic waste to accumulate, causing itching or skin irritation. Less movement, nutritional intake, and lower circulation can also create issues with the skin as well. Frequent turning can potentially help avoid skin breakdown. Certainly, monitoring for skin infections. Consider things like antihistamines. In severe cases, I've seen nalbuphine can be used, especially in patients with severe itching where there's opioid toxin buildup that's causing that itching. But again, that's a controlled substance and something that again should be reserved for severe cases. Next, let's talk about the neurological system. Disorientation or delirium is common, like we talked about in hospice patients. It can be caused by changes in sleeping patterns, toxin buildup due to organ dysfunction, or other factors. Keeping patients comfortable, gently redirecting them unless a hallucination is comforting. Considering clocks, calendars, identification of self to the patient, your relationship to the patient, sometimes those sorts of things help. And really, some patients do say hurtful things to loved ones. And this is where hospice care providers are in a great position to educate on the different symptoms, the dying process, and to offer tips for coping in these situations. Myoclonus is also something to discuss, certainly different from seizures, but myoclonus is a brief involuntary twitching of muscles. It may occur as part of the dying process in some patients. Often it's caused again by buildup of opioid metabolites or other medications with organ dysfunction as organ function declines as you get closer to death or in the presence of dehydration. Certainly, again, this is not to be confused with seizures. One thing I've read about that's interesting is communicating with the dying individual. Studies have shown that the brainstem seems to respond to sound even while a patient is dying. Speaking softly to a dying person, especially of treasured memories, can certainly comfort them. If they can speak, let them, but try to be aware if they prefer your silent presence instead. As patients become weaker, walking may no longer be possible and they may lose bowel and bladder control. So elimination again is something to think about. Incontinence products should be used to avoid skin irritation. As fluid intake decreases, urine output also decreases. There's also slower circulation through the kidneys and urine becomes more concentrated. So you may actually see some swelling occurring at the feet, the ankles, the hands, the face, lungs, again, because there's slower circulation, causing an inability to process fluids. As we discussed earlier, just take caution providing artificial IV fluids in patients. The respiratory system. Effects of the respiratory system are one of the most recognizable symptoms that occurs close to death. There are several breathing patterns that indicate impending death, but there's a couple that I want to highlight here for you. The first is called Cheyne-Stokes breathing, which occurs when there is a pause in breathing and then breathing returns with heavy panting. The other breathing patterns may be referred to as agonal and ataxic breathing. Both agonal and ataxic breathing commonly have snorting, gasping, gurgling, and moaning associated with them. Patients may also have a rattling sound in the back of the throat, and this is caused by the inability of the patient to swallow saliva. To assist with comfort, try elevating the patient's head, consider turning them to the side to drain secretions. Also, providing comfort to families by teaching that although their loved one's breathing may be noisy, clinicians do not believe the noise is a sign of discomfort necessarily if there's no grimace and no restlessness. Pronouncing death. Each state or province has different laws and regulations determining who's authorized to pronounce death. Pronouncing death has a list of specific steps that must be followed. So you should discuss with your hospice team what those steps are for your state. This is very important. Typically, it involves examining the patient, notifying their family, recording death with the proper parties, etc. An examination should include feeling for the absence of a carotid pulse, and medical documentation is very important, as you know, as healthcare providers, and must include whether the patient's family members and attending physician were notified. Again, each state may have different laws and rules and regulations, so make sure to consult with your state laws and regulations as well as what your hospice rules and policies are there. Caregivers should be educated to notify the hospice as soon as possible if death is imminent and upon death. Certainly, calling 911 is not the appropriate method, and ensuring that you discuss with your patients and caregivers that that is not an appropriate method. So, educating the patients and the caregivers on what to do is very important. The hospice prepares the body typically for removal from the home and notifies the physician, the funeral home, and any authorities that are required by law. Certainly, each hospice has their own policies and procedures on how this is done, but this is a general overview of this section here. Hospice care providers are a wealth of information and can help families in many, many ways. And this includes things like recommendations for disposal of biological waste and disposal of medications. Each state is different, and you should be clear about local regulations that govern waste disposal and medication disposal and ownership of medications upon death. Make sure to offer bereavement support as well and honor any cultural or religious beliefs of the patient and the family. This is our last question of the set here. True or false, the hospice team is not responsible for educating the family on disposal of biological waste or medications for the deceased? Just take a moment to think about if that's true or false. And certainly that's false. Make sure you know your state laws for medication and biological waste disposal, and certainly in a great position to educate patients and families of how to do correct disposal. This is my last slide here of this set, and I wanted to focus here on the family because certainly once the patient passes, the family is the focus here for the hospice. Even if death is expected, raw emotion can certainly take over, allowing caregivers to say goodbye. If hospice is there, they may be able to prepare the body to view. And I've heard things like including placing a towel under the chin, placing an incontinence pad on the bed, holding the eyelids closed or holding the eyelids closed or placing a small piece of surgical tape to keep them closed. Typically, the funeral home will arrange to transport the body, and the physician is responsible for signing the death certificate. Again, different laws and regulations by area, and certainly know those. And here at the end, I just want to take a moment to thank each and every one of our hospice care providers. What you do is truly invaluable. The nurses, the social workers, the physicians, the chaplains, and the other staff members that make these hospices run really well and caring for patients are among the most selfless and caring people in the healthcare world. And I know I personally thank you for all of your hard work. I know that the work is very difficult and sometimes thankless, but know that we that have experience with hospice are certainly grateful for you. We are at the end of the presentation. We have our names here in our emails. If there are any questions or concerns, please feel free to reach out to us at Hospice Choice RX. If you have any questions about us, about our platform, about where the content we're going to be placing is, and again, we thank you for your time and attention today. Again, for our clients, we will place this presentation in the slide deck in our resources section, and make sure that if you're one of our clients to go into the Relias platform, claim your continuing education if you're a nurse or a social worker. But again, I thank everybody for joining us today and spending a little bit of your Thursday with us. Thank you again, and we will talk to you soon.